A good day again to everyone, guys. So, here's our last topic for term two, and we are now going to discuss peripheral vascular disease or peripheral vascular diseases. Now, we start out with these two, Buerger's disease and Raynaud's disease. We have a comparison here. So, if for Buerger's disease, it's a recurring inflammatory infiltration. So, it's also like the coronary artery disease, where there is a plaque formation on the intimal wall, but instead of it being in the coronary arteries, the plaque is found at the lower extremities or the blood vessels of the lower extremities. So, it can cause either partial or complete occlusion of the intermediate and small arteries of the veins of the lower feet. And it rarely affects the upper extremities, but it sometimes affects them as well, such as the hands. So remember, there's plaque formation, most likely of the blood vessels of the lower extremities in Buerger's disease. Raynaud's disease, it's a form of intermittent or episodic arteriolar vasoconstriction, this time predominantly of the hands. If for Buerger's disease, it's commonly affecting the lower extremities. The Raynaud's disease, they're commonly affecting the upper extremities. The other name for Buerger's disease is thromboangiitis obliterans, while Raynaud's disease is vasomotor arterial disease. Etiology for Buerger's disease, the cause, both of them have unknown cause, but there are risk factors associated to it. For Buerger's disease, autoimmune vasculitis, when we say vasculitis, this is the inflammation of the blood vessels, and this is brought about by chronic cigarette smoking. That is why if you see those posters at the hospital with regards to a deformed individual with an ugly face, a face with deformities, and so on, in regards to cigarette smoking, one of the things mentioned there on that poster would be Buerger's disease, because this is highly associated with cigarette smoking. For Raynaud's disease, it's usually associated with emotional stress and hypersensitivity to cold. For Buerger's, it's more common in men, 20 to 35 years of age, all races. While for Raynaud's disease, it's common to women this time, 20 to 40 years old. So take note, Buerger's disease, commonly occurring in men, Raynaud's disease, commonly occurring in women. And take note, since there is hypersensitivity to cold in Raynaud's disease, they are commonly occurring in winter months, but we don't have winter here in the Philippines. They usually occur in the northern or southern hemisphere, not near the tropics. Next, in Buerger's disease, thrombus formation can occur due to that plaque that has built up, and that can later on lead to inflammation because and narrowed lumen of the blood vessels. Since the artery is unable to transport adequate blood volume because of that blockage to the tissue during exercise and rest, this now will lead to total occlusion, leading to the appearance of signs and symptoms. They will experience lower extremity pain brought about by total occlusion of the arteries of the lower extremities. Cold stress. There's episodic arterial spasm. Now, what happens here if there is constant arterial spasm brought about by cold weather, the intimal wall is going to thicken because of hypertrophy of the medial wall, resulting to a constant and repeated spasm or constriction. So it somehow is like being exercised every now and then because of the spasm, leading to the hypertrophy of the smooth muscles of the medial wall. If that happens, there will be sluggish blood flow, leading to total occlusion of the arteries, again presenting the signs and symptoms of Raynaud's disease. So for Buerger's disease, symptoms resulted from occlusion of artery leading to ischemia, and it will be complicated later on at later stage by infection due to minimum or due to the ischemia. There's minimal blood-rich oxygen circulating in the lower extremities. One of the signs that I've mentioned earlier is pain with exercise. The patient is going to feel pain, and this is the most common symptom presented by the patient. Usually, it is bilateral, symmetric at the arch of the foot. It may occur during rest, and sometimes it can be persistent. Intermittent claudication, this is the most common symptom of arterial insufficiency, which occurs during exercise. So if the patient, let's say for example is running or walking, and they feel pain while walking or running, that is intermittent claudication brought about by the occlusion of the arteries of the lower extremities. While for Raynaud's disease, symptoms result from arterial spasm leading to ischemia. Pain again will be felt by the patient due to cold stress, usually at their fingertips. Now, for Buerger's disease, skin color and temperature is going to change at the lower extremities. And if further ischemia occurs in the patient, there will be skin ulcerations leading now to gangrene. This can occur in the patient. Infection can occur due to these ulcerations. You can see that from the poster at the hospital. And the nail beds, the capillary refill is greater than 3 seconds, usually that of the toes. Peripheral pulses may be diminished, and you can um, hear or auscultate an audible bruit. Now, for Raynaud's disease, there's also skin color and temperature changes. So their skin, the hands will appear pale. They will also have ulcerations and gangrene, and same with the nail beds. The fingernail or fingers will have a capillary refill that is greater than 3 seconds. So this is the hand of a patient who has Raynaud's disease. So here's another example. And as you can see here in these examples, the fingertips or the fingers themselves are appearing pale or even cyanotic. As you can see, the fingertips of this patient, and it can become gangrenous later on. It can become necrotic. So it's very, very dangerous to have this condition. This one is for Buerger's disease. So it can become necrotic and gangrenous if it further worsens. Now, for the physical examination, they are going to assess for segmental limb pressure, the blood pressure. Doppler ultrasonography is also going to be done to determine which area has the occlusion, including arteriography or angiography, that will also detect which one or which artery is occluded. And they are going to do transcutaneous oximetry to determine the oxygen levels of the extremity. MRI can also be done in order to check which artery is affected. In the physical examination of Raynaud's disease, one of the tests done is the cold stimulation test. So the fingers are placed in an iced water bath for 20 seconds. The patient is going to have or to be will be positive for Raynaud's disease or phenomenon if the temperature of the fingers did not return to normal after 20 minutes. So it should return to normal after 20 minutes. But if it doesn't return to 37 degrees Celsius, then the patient is positive for Raynaud's disease. So this is the segmental limb pressure in order to detect for discrepancies in the blood pressure. This is the Doppler ultrasonography, and they are also testing here the pulse rate of the patient. So they need to assess for the oxygen in the tissues if it is adequate enough. These are angiographies. As you can see here, there are occluded blood vessels of the lower extremities brought about by Buerger's disease. This one now is for the hands. For Raynaud's disease, occlusions also are seen in the angiography. Now, what is the medical management here? For Buerger's disease, we give anticoagulants in order for the blood not to clot, such as heparin and warfarin. Take note of the PT again and the PTT when giving anticoagulants such as heparin and warfarin. Thrombolytics or fibrolytics, the alteplase, reteplase, in order to dissolve the blood clots that are occluding the arteries. Vasodilators will be given as well in order to, or for blood to pass through the artery that has a partial occlusion. Now, for Raynaud's disease, calcium antagonists are going to be given, or calcium channel blockers, in order to dilate the blood vessels of the arteries in the hands. Vascular smooth muscle relaxants will also be given, and vasodilators. So same with hypertension. The drugs given to hypertension can also be given to both Buerger's and Raynaud's disease. Now for Buerger's disease, they need to maintain a warm environment because a cold environment can further vasoconstrict the blood vessels. Legs in a slightly dependent position and avoid elevating the legs. Because if the legs are elevated, of course, blood is not going to flow through them because of the force of gravity. Avoid vigorous massage of the extremities as well. And advise the patient to avoid constrictive clothing and avoid crossing the legs. So tell them not to wear tight fitting pants or shoes because this can further constrict the blood vessels. For Raynaud's disease, same management to that of Buerger's disease, and advise the patient to wear gloves and warm socks during winter months, and avoid cleaning the refrigerator, and also avoid handling frozen foods because this can further aggravate their condition. Avoid occupations that require constant exposure to the cold as well. As much as possible, if it's snowing or if it's the winter season, they should avoid going out because of the snow, because of the cold weather. For Buerger's disease, they need to quit smoking. We need to promote activity or exercise, general exercises as well, such as Buerger Allen exercise will be done. Maintain skin integrity and prevent infection for this patient. In Buerger Allen exercise, this is easy for the patient to do because we're just going to instruct the patient to rotate their feet and do dorsiflexion, plantar flexion in order to execute this type of exercise. Now, what would be the surgical management? They are now going to do arterial bypass surgery. So they're going to replace those arteries that are no longer or that are already totally occluded by plaque with arterial bypass surgery. They're going to use other blood vessels, such as the veins, also from the lower extremities. Percutaneous transluminal angioplasty. So same with that of the coronary artery disease in order to remove the plaque that is building up in the arteries of the lower extremities. If there is infection and further, like with the picture that you've seen previously, those type of gangrenous infection need to be amputated. Same as well goes for um, Raynaud's disease. And for sympathectomy, they need to excise a nerve in order for the sympathetic nervous system that is supplying, or the nerve supplying the upper extremities of the patient with Raynaud's disease not to tell the blood vessels to do vasoconstriction or spasms. So that may be done as well. So this is an example of the Buerger-Allen exercise where they rotate, do plantar flexion and dorsiflexion of their feet, and they elevate the feet every 2 to 3 minutes. So this is how the bypass surgery is done with patients who have plaque formation of the arteries of the lower extremities. So most probably they are going to use the saphenous veins in doing this bypass surgery. So here, they're going to insert a catheter, balloon tip catheter, in order to do this transluminal angioplasty. So this balloon tip catheter will cause the plaque to be or to be flattened by the balloon in order to increase the lumen of the affected blood vessel. Stents may be used as well, same as that for the coronary artery disease. And sometimes they need to scrape this off, the plaques. So here, they're scraping it off with a catheter. This is the removal of the thrombus that has been formed in the blood vessel. So as you can see here, this needs to be amputated since it already has a severe case of gangrene. Okay, other vascular disorders. We have aneurysm. Aneurysm is the permanent bulging or stretching of an artery in which the dilation is 2 times or greater than the size of the artery. So when we say aneurysm, there's bulging of an artery. So if it bulges, if it indicates that the artery is already weak. This happens because of the high blood pressure that the artery has. And tendency, if the artery cannot take it anymore, it is going to bulge. It is going to weaken and create these bulges. 3 sites commonly affecting are the aortic arch, the thoracic aorta, and the abdominal aorta. Now we go to thoracic aortic aneurysm. Approximately 70% of all cases of thoracic aortic aneurysm are caused by atherosclerosis. They occur more frequently in men between the ages of 50 to 70 years and are estimated to affect 10 out of every 100,000 older adults. The thoracic area is the most common site for a dissecting type of aneurysm. Now we go to the types of aneurysm. We have a false aneurysm here. This is actually a pulsating hematoma. So as you can see here, it did not totally outpouch or bulge. The medial wall is still intact in this false aneurysm. But for true aneurysm, unlike that of the false one, the medial wall together with the intima has already bulged in true aneurysm. For fusiform aneurysm, as you can see here, there is symmetric spindle-shaped expansion of the entire circumference. So both sides has that outpouching. Both sides have a bulge, unlike that of the true aneurysm. While for saccular aneurysm, there is a bulbous protrusion of one side of the arterial wall, as you can see here in this description. While for a dissecting aneurysm, it's usually a hematoma that splits the layers of the arterial wall. So probably this one, the tunica adventitia, has split off with the tunica media. Now, etiologic classifications of aneurysm. There are congenital types. It's primary connective tissue disorders such as Marfan syndrome, Ehlers-Danlos syndrome, and other diseases such as focal medial agenesis, tuberous sclerosis, Turner syndrome, Menkes syndrome. You are going to learn this more in your other concepts of medical surgical nursing with regards to these connective tissue disorders. And we have mechanical or hemodynamic classification, poststenotic and arteriovenous fistula and amputation related. Traumatic, pseudoaneurysm due to penetrating arterial injuries or blunt arterial injuries. Inflammatory, which is non-infectious, so no microorganism is involved here. Associated with arteritis such as Takayasu disease, giant cell arteritis, SLE, or systemic lupus erythematosus, Behçet syndrome, Kawasaki disease, and periarterial inflammation such as pancreatitis. You'll learn more about this in your concept with regards to infection and inflammation. I think that's for second step. And infectious or mycotic, such as bacterial, fungal, and spirochetal infection. Pregnancy-related degenerative. So it's non-specific inflammatory variant. It's related to pregnancy. Or anastomotic or post-arteriotomy or graft aneurysms brought about by infection, arterial wall failure, suture failure, or graft failure. So this can happen even though the patient or the surgeon rather has already repaired that aneurysm. This can or aneurysm can further occur, brought about by complications from that surgery. Clinical manifestation. Some patients are asymptomatic in this condition, but pain is constant and occurs when the person is lying down or is in a supine position. And if there's thoracic aneurysm, of course, the patient is going to feel dyspnea because the outpouching or the bulging will exert pressure on the lungs of the patient, and there may be paroxysmal cough, of course. Hoarseness, stridor might be heard from the patient, weakness or complete loss of voice, aphonia, resulting from a pressure in the laryngeal nerve brought about by that bulging in the thoracic aorta. Dysphagia as well, because that aorta can exert pressure also on the esophagus of the patient. That's why there's difficulty of swallowing. Now, to diagnose aneurysm, chest x-rays might be done, CT scan, or CT angiography. Again, take note of the dye. Check for allergies in iodine. MRA or magnetic resonance angiogram, so it's similar to MRI. And TEE, transesophageal echocardiography. So they are going to insert a sonogram into the esophagus in order to visualize the thoracic cavity for the aneurysm. Medical surgical management. Control blood pressure through antihypertensive drugs. We all know this now. The beta blockers, the ARBs, ACE inhibitors. And repair of aneurysm using endovascular grafts. This is through open heart, or what do you call this? Through open thoracic surgery, rather, not open heart surgery. So this is what they are going to do. They are going to insert an endovascular graft. So this is now going to bypass the graft that has been inserted in the aorta, will bypass that aneurysm. Just in case this ruptures, of course, it is already bypassing that aneurysm. This is an aortic graft implant, just in case there is a bulge in the aortic arch. So they are going to incise and place a tube inside a graft. Nursing management. Place patient in supine position after an endovascular repair. Vital signs and Doppler assessment of peripheral pulses are monitored every 15 minutes post-op. Assess for bleeding, pulsation, swelling and pain, and hematoma from the hematoma formation at the axis site. So in the area where the doctor has done the surgery, assess for bleeding, pulsation, swelling, pain, and hematoma. Check for signs of embolization such as extremely tender, irregularly shaped cyanotic areas as well as changes in the vital signs, pulse quality, bleeding, swelling, pain, or hematoma. Check for temperature as well every 4 hours because there might be signs of post implantation syndrome. The body might reject those implants that have been done in the aortic or in the aorta of the patient. Post implantation syndrome typically begins within the first 24 hours of stent graft placement and consists of spontaneously occurring fever, leukocytosis, and occasionally transient thrombocytopenia. This can occur since that stent is a foreign object that is placed in our body. So watch out for that. That is a defense mechanism of the body to protect itself from foreign substances. So check for post implantation syndrome. Check for signs of hemorrhage as well. Now we go to varicose veins. There is a dilation of veins brought because of lack of muscle support results from prolonged venous stasis. Common sites of varicose veins are the saphenous vein, leg vein, hemorrhoids. This is varicosities of the anal area, the rectal area, and esophageal varices can occur as well. So as you can see here, the veins of the lower extremities can become tortuous. When we say tortuous, they can become twisted. In Tagalog, para na siyang nagmumukhang isaw, yung veins ng lower extremities. As you can see from this illustration here. So look at the veins of these patients who have varicosities. Now, prevention. We need to tell patients to avoid activities that cause venous stasis, such as wearing socks that are too tight at the top, crossing the legs at the thighs, and sitting or standing for long periods of time. That's why for people like me, if there's no pandemic, I am the type of teacher that do not sit while doing a lecture. I roam around. So I stand or roam around for the whole day while teaching. Traffic enforcers, they're out there standing for long periods of time. Even sales ladies from malls, they might suffer from this as well because they are standing for prolonged periods of time. So we need to advise patients who are sitting or standing for long periods to frequently elevate the legs 3 to 6 inches higher than the heart. Patient is also encouraged to walk 30 minutes each day. And graduated compression stockings are worn by the patient, especially knee-high stockings are very, very useful. So these are example of graduated compression stockings or socks. So the pressure is greater at the distal portion of the feet, while the pressure is lower at the proximal portion. Now, what are the surgical management in varicosities? Ligation and stripping. So they are going to strip the veins that are involved or that the veins that have the varicosities. They're going to ligate it and strip, or they are going to do thermal ablation. So they are going to insert a laser tip catheter or fiber into the vein, and the laser is going to be activated and close the vein. In endovenous laser treatment is thermal ablation. For sclerotherapy, it's similar to laser treatment, but instead of laser, they are going to use chemicals that will cause the closure of the varicose veins. Nursing management advised that these surgical procedures are outpatient department. So patient is advised to walk every hour for 5 to 10 minutes once the sedation has worn off. Advise the patient that graduated stockings or compression stockings are worn about 1 week after the vein stripping. Foot of the bed should always be elevated to promote venous return, and standing and sitting for long periods of time are highly discouraged. So that's it, everyone, for peripheral vascular disease. If you have any questions with regards to it, just ask me about them. And again, good luck to your exams. I hope that you have started reviewing for your cardio contents. Again, thank you everyone for attending this lecture and have a great day.